Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. Our eyes are often described as the windows to our souls, but they can also reveal crucial insights into our overall health. For people living with rheumatic disease, the eye can be one of the most important manifestations of their rheumatic disease. Many diseases, including rheumatoid arthritis, spondyloarthritis, sarcoid, relapsing polychondritis, can all affect the eye in various ways. For rheumatologists, the eye is often a black box, or should I say, a black globe. And there is no better way of understanding rheumatic manifestations of eye disease than to speak with a true expert, a rheumatologist who has dedicated his career to unraveling the mysteries of ocular manifestations in rheumatic disease. Dr. James Rosenbaum is currently Senior Vice President for Research at Corvus Pharmaceuticals and Chair Emeritus of the Legacy Devers Eye Institute in Portland, Oregon. Previously, he was Professor of Ophthalmology, Medicine, and Cell Biology at Oregon Health and Science University and Chair of the Division of Arthritis and Rheumatic Disease for 21 years. He's one of the world's most impactful uveitis scientists based on the number of publications and citations. In fact, he was the world's only practicing rheumatologist to have headed a department of ophthalmology. He has authored hundreds of manuscripts and has been awarded numerous national and international awards in rheumatology and ophthalmology, including the American College of Rheumatology Distinguished Service Award in 2022 and the ACR Clinician Scientist Award. In this episode, Dr. Rosenbaum and I discuss his accidental stumble into the world of inflammatory eye disease, and we focus our discussion on uveitis, including what it is, how to determine whether people with uveitis have an underlying rheumatic disease, which patients with rheumatic disease to refer to ophthalmology, and the various ways that he treats uveitis. Throughout our discussions, you will hear the words of a true master, sharing his valuable insights gained from years of practice and research, and through it all, you will not escape his infectious enthusiasm for uveitis. Please enjoy this entertaining and educational discussion with Dr. James Rosenbaum. Jim, welcome to the show.
Thanks, John. It's a pleasure to be here.
So let's get started. How did you become interested in rheumatology?
Oh, genetics. My dad was the first rheumatologist in the state of Oregon. So he trained under Hench at the Mayo Clinic and moved out west. And I had no choice, family business.
And I think that's exactly right. You know, from what I've been reading about you, it sounds like your father was a physician and a rheumatologist, and many other members of your family were physicians as well.
Yes, I have two brothers who are physicians, uncles and first cousins, and then my wife and two daughters are physicians. So,
oh my goodness. So you really did have no choice.
That's right.
So, rheumatology is certainly, I think, the most interesting specialty. But early on, it sounds like you took sort of an interesting course in your rheumatology career by being interested in the eye. How did that happen?
By mistake. So I was intimidated by eyes for sure. As a medical student, my best friend said, Rosenbaum, learn the mnemonic TEON, and you'll know everything you'll ever need to know about the eye. And of course, TEON is 2 eyes, 1 nose.
I like that.
Yeah, I could not use the ophthalmoscope with my left hand. I was a klutz. I'm still a klutz with slit lamps and lenses and indirect ophthalmoscopy. But I did my fellowship at Stanford under Hugh McDevitt. And McDevitt was the father of immune response genes. Some people who knew Benacerraf would say that he was the father, but those who trained with McDevitt believe that he was the father. So I started my fellowship in 1978, and that was exactly 5 years after the group from London and the group from UCLA had announced that there was this molecule called HLA-27, it was then called A27, that had this phenomenal relationship to ankylosing spondylitis and reactive arthritis and acute anterior uveitis. So I thought, hey, I can figure this out. I'll just take the kinds of bacteria that trigger reactive arthritis, like Shigella, Salmonella, Yersinia, and I'll kill them and I'll inject them into the feet of rats. The rats will probably get arthritis. And I did that, and I diligently went to visit the rats every day. There was no hint of any synovitis whatsoever. But the eyes got irritated and crusty, and I was just very lucky that my cousin was in training at Stanford in ophthalmology.
Ha.
So cousin Bob said, put those eyes in formalin, bring them to me, and I'll tell you what's going on. And a couple weeks later, he said, hey, all these eyes have uveitis.
Ha.
And I said, a swear word, really. I was not happy because I literally did not know what uveitis was. I had no clue whatsoever. And he thought it was neat, but I didn't think it was so neat. Eventually, we parsed out that it was the endotoxin in the bacteria that was causing the uveitis. We didn't need to put the endotoxin anywhere near the eye. We could inject it intraperitoneally, subcutaneously into the footpad. And we were seeing universal eye inflammation. And I wanted to try to understand that. So I started volunteering at a pretty famous uveitis clinic at University of California, San Francisco. And before I knew it, they said, hey, you can't just watch. You have to use that slit lamp. And you need to learn how to use an indirect ophthalmoscope. So I did that really reluctantly. And then I joined the faculty at UC San Francisco. And eventually I also held a position at California Pacific in San Francisco. But a position opened up in Portland on the faculty. And the chief of medicine was a good friend of the chief of ophthalmology. And the chief of ophthalmology said, when you come to Portland, I'm putting you in charge of the uveitis clinic. And I said, no way. I said, my patients are rats and rabbits. I'm really good at taking care of rats and rabbits, but I don't do people. And he said, you have more experience than anyone else on my faculty, which was sad, but absolutely true. Uveitis is still pretty obscure. There may be 150 uveitis specialists right now in the U.S.
Wow.
And he assigned to me an incredibly talented, kind, wonderful retina specialist to be my mentor. And before I knew it, I was examining patients. And they even gave me an exam table in the middle of the eye clinic. So it was not my intent, but it's been a good ride. I've been doing it since 1985, running a uveitis clinic.
And so the uveitis clinic was within the ophthalmology department?
Exactly.
Interesting. So as part of the training, I imagine you got trained in sort of looking at the eye in various ways. Were you also trained in any procedures?
Fortunately, no.
Okay.
One of the things that we do in the care of patients with uveitis is we inject corticosteroids in and around the eye. And I did do that one time so that they always assigned a resident or a fellow or a faculty member to assist me to make sure that I wasn't overlooking something. But the most procedurally thing that I ever did was one periocular injection. I don't even remove lashes that are ingrown or
Got it.
I defer to a real ophthalmologist.
Got it. So you stick with your bounds, but certainly it sounds like, perhaps your experience of rheumatology and understanding the immune system, and then your experiences in research, with animals, sort of allowed you to understand uveitis and hopefully, help with the management.
I have lacunae in my knowledge, as we all do, but I also have strengths. So patients with uveitis usually or most often have an immune-mediated disease. And of course, I knew the immunosuppressives and when they came along, the biologics, better than virtually any other ophthalmologist.
Yeah.
But I knew less about the eye and its anatomy and certainly surgical procedures than any ophthalmologist. I knew much less. So the whole was greater than the sum of the parts. Working with an ophthalmologist has always been essential in what I've done. And I think I've brought to the table some knowledge, but I've also gained a great deal from that partnership.
Fantastic. And it's so interesting to hear how sort of serendipity, right? Your study, your desire to understand HLA-B27 and trying to replicate a mouse model, ended up you becoming a uveitis specialist. Fascinating.
Sure. The trick about work is that it shouldn't be work, right? You find your passion and you enjoy it. And uveitis and ocular inflammatory disease became my hobby, and it's been fun.
That's awesome. So let's talk about uveitis. Can you explain sort of to a rheumatologist what uveitis is? We often think, it's inflammation of the eye. Sort of, given your 30 plus years in this field, how do you explain uveitis, to patients and to others?
Sure. So uvea is the Latin word for the middle of the eye, which uvea translates to grape. And somehow those Roman anatomists thought that if you peeled off the outer layer of the eye, it was a grape-like structure underneath. So they called it the uvea. And itis, of course, means inflammation. So normally there are no white cells in the front of the eye, just like there should be virtually no white cells in cerebrospinal fluid. And if you have inflammation, that blood aqueous barrier is destroyed, just like the blood-brain barrier or the blood synovial barrier or the blood pulmonary barrier. And with a slit lamp, you see inflammation. It's incredible. You see those white cells. So you have no doubt that something's amiss. And not only do you see white cells, you see increased vascular permeability, which is the other universal hallmark of inflammation. I mean, some people think that the eye was created for vision, but I think the eye was created so we could study inflammation.
I love it because you could see it with your own eye, right? That's pretty impressive.
As a rheumatologist, you stick that needle in the knee or the shoulder or the elbow. It's invasive.
Yeah.
But with the eye, you can watch it. You can make movies of the inflammatory process. You can, if you're dealing with an experimental animal, you can label those white cells with different colors and watch them interact. You can, do real-time movies. You can do slow motion, and it's amazing. So uveitis is inflammation of the uvea, and the parts of the uvea include the iris, the ciliary body, and the choroid, which is the vascular area adjacent to the retina. And how do we diagnose synovitis? How do we know that someone's got an inflammatory knee process as opposed to a mechanical knee process? We stick a needle in it and we count the white cells.
Right.
So we know someone has a uveitis if there are white cells. And when you put the needle into the knee, you're looking at the synovial fluid. And by the same token, when we're diagnosing uveitis, we're looking at the aqueous fluid or the vitreous fluid more than the iris, ciliary body, or choroid. So we're looking at sort of what's sweated off into a fluid that we can visualize more easily than the solid tissue.
Interesting. So, I sort of think about uveitis in two settings. We have the patients that are initially seen by ophthalmology and diagnosed with uveitis, and often those patients get referred to rheumatology to figure out if there's an underlying systemic condition that's contributing. And the other setting that I think about uveitis is in some patients with rheumatic disease that we're thinking about uveitis as a potential complication of their condition. So I want to start thinking about the first case, right? Those patients that are apparently healthy, they have an inflamed eye, they're diagnosed with uveitis, and then they get sent over to rheumatology. So what should our job be at that time in trying to figure out, what the cause is of this patient's uveitis?
Mm-hmm. Take a history.
Looking for what in specific?
Well, so, let's say you've got a patient with joint disease, right? It matters whether it's small joints or large joints. It matters whether it's symmetric or asymmetric. It matters whether it started insidiously or suddenly. And all of those same sorts of parameters help you nail down what's the cause of the uveitis. So arguably the most common form of uveitis that I can identify is HLA-B27 related. And almost always, there are exceptions, but almost always that's sudden onset, unilateral, anterior uveitis that resolves within no more than 2 months and tends to be recurrent. So it has a phenotype. Sarcoidosis is more variable, but it has a phenotype. You're a pediatric rheumatologist. JIA has a very consistent phenotype, the uveitis associated with JIA. Bilateral, insidious onset, anterior. Again, they're exceptions, but knowing that phenotype clues me in to what to look for. And I think it's asking too much of a rheumatologist to be familiar with every phenotype, but a history will help. I've tried to share my experience in up to date in textbooks of rheumatology to help and give clues. And there is something called the American Uveitis Society that's a collection of experts in ophthalmology who can act almost like rheumatologists and have that knowledge to be able to subtype or phenotype the uveitis.
Fantastic. I like it. So it's sort of similar, like you mentioned, similar to pattern recognition of joint presentation, pattern recognition of the eye presentation, whether it's one-time, recurrent, bilateral, unilateral, acute or insidious onset, and then the location of the uveitis. So these are all things that I guess, hopefully, the ophthalmologist will be able to describe, by the time that they make it to rheumatology clinic.
It's identical, except that sometimes they're curveballs. So, when we evaluate joint disease, every once in a while we encounter an infection instead of an inflammation. So tuberculosis occurs in the eye, syphilis occurs in the eye, lymphoma can occur in the eye. And many of these have patterns that you can see with a dilated exam, with special instruments or with photographs that, again, it shouldn't be the responsibility of the rheumatologist to identify those. But you have to have confidence in the ophthalmologist with whom you're working to be sure that the ophthalmologist has excluded lymphoma or an infection as the underlying cause. And, sometimes it's a probability. So I don't think this is tuberculosis. Let's start the patient on some prednisone and some methotrexate. 2 months later, it's getting worse or it's not getting better soon enough. Did I overlook an infection? What do I have to think about? But again, it's a partnership, and you're only as good as that partner.
Got it. No, that makes sense. And in terms of the rheumatologic workup, thinking about HLA-B27, asking about sort of symptoms of inflammatory back pain and inflammatory joint pain, things like that. That makes sense for that type of arthritis. Thinking about sarcoid laboratory or imaging studies, aside from the a thorough history and physical exam that you sometimes do to try to figure out the cause of the patient's uveitis.
Right. So the typical ophthalmologist will do things like an ANA and a rheumatoid factor. Right? Rheumatoid arthritis is really not in the differential diagnosis of uveitis as far as I'm concerned. And lupus does cause uveitis, but extremely rarely. So the two diseases that are somewhat silent and easy to overlook that I don't want to miss would be syphilis. So when I started, we would do RPRs. Now we do FTAs, and sarcoidosis. Syphilis is probably 1% of the uveitis in most American practices. Sarcoid, depending on where you are, is pretty substantial. So I practice in Portland, Oregon. Portland, Oregon has the smallest African-American population of any city metropolitan area over 1 million in the country.
Wow.
And about 5.5% of my patients have sarcoid that I can identify. So we always do a chest x-ray if the uveitis is of unknown etiology. I mean, if I know that someone's got ankylosing spondylitis and they've got sudden onset unilateral, I don't need a chest x-ray.
Right.
But if someone comes in, I've evaluated them, I don't know the cause of the uveitis, I like to get a chest x-ray. And then because of the amount of radiation, I don't routinely get a chest CT, but if someone's over 40 and it's a relatively severe uveitis that I'd like to nail down, I will get a chest CT, which I think is an order of magnitude more sensitive than a routine chest x-ray.
Yep.
Other tests, again, depend a lot on the phenotype or the symptoms. HLA-B27, I think, is helpful if someone has sudden onset unilateral. It puts the uveitis in a niche, usually. Of course, your B27 could be a coincidence. Most people who are B27 positive don't get spondylitis and don't get uveitis. But if they've got sudden onset unilateral and they're B27, that's most likely they're related. And it also means that it's likely to be recurrent. It also means that if they're having really frequent episodes, something as simple as sulfasalazine can reduce the frequency of those recurrences. IBD, inflammatory bowel disease, both Crohn's and ulcerative colitis, fairly frequent cause of uveitis. And something as simple as a stool calprotectin, pretty good screen for IBD. There's an entity that we see commonly in the uveitis clinic called TINU, tubulointerstitial nephritis with uveitis. You're a pediatric rheumatologist. You should be familiar with TINU.
Sure.
So TINU is actually more than 1% of the uveitis that I see. It's incredibly distinct. It's usually a child. It's bilateral. It's sudden onset. It's anterior. All right. So sudden onset anterior means that the eye is red and sensitive to light. So you don't need a slit lamp to know that, somebody's probably got sudden onset anterior. And they don't come in saying, "Hey, doc, my kidneys are inflamed." You've got to get a urine to show that there's sterile pyuria. And then they spill, but because it's a tubular inflammation and not a glomerular inflammation, they don't spill large proteins. they spill smaller proteins. So we measure beta-2 microglobulin in the urine. And most rheumatologists, even pediatric rheumatologists, I think, are not familiar with TINU. Yep. These patients come in with a SED rate sometimes of 100. They ache. They have arthralgias. They have abnormal liver enzymes, not striking, but 1.5 times normal. And unless you know the entity, you miss it. And once you know the entity, you give them a modest dose of prednisone, and it's like a miracle.
Amazing.
So, again, the pattern recognition and the familiarity is really critical.
Yeah. And the other type of that was wonderful. The other type of patient I wanted to discuss is patients that have known rheumatic disease and that we think about uveitis as a potential complication. And so are there patients that you think should be routinely sent to ophthalmology for evaluation uveitis, or to see, whether there's signs of uveitis or complications from, previous episodes of uveitis? How do you think about that?
So most often uveitis is symptomatic, but there's a major exception, and that's the subset of patients with JIA who have this insidious onset, usually bilateral disease. And that subset is usually pauciarticular, usually but not always female, often ANA positive, but frequently not, and usually the onset of disease before age 7. So they're at high risk, and you probably know better than I that both the American College of Rheumatology and the American Academy of Ophthalmology recommends screening for that subset. And if you have those demographics that I just described, the screening should be every 3 months. And if you go more than 4 years and you don't find it, you can start doing it a little less frequently. But that's a high-risk group.
Yep.
The others, say you've got B27 and you're a child and you get uveitis, it's going to be symptomatic. You don't need to routinely screen. TINU, symptomatic. Sarcoid, I'd argue if it's asymptomatic, you don't need to treat it.
Right.
So either it's symptomatic and it needs to be evaluated, or it's very mild because it's asymptomatic. So for the most part, I wouldn't take someone with psoriatic arthritis and say, you need to see the ophthalmologist. Someone with ankylosing spondylitis and say, you need to see the ophthalmologist. The only ones who routinely need referral are the kids. And especially that one pauciarticular early onset subset.
Got it. And it always struck me like, what's the deal with the joint and the eye, right? What do they have in common that, JIA affects, particular set of joints, and then the eye out of, all the organs in the body? Any thoughts?
Yeah, I stay up at night wondering. So there are some antigenic overlaps, like hyaluronic acid and aggrecan.
Oh, interesting.
But it is a mystery. There was a paradigm-shifting paper in Nature last December. The first author was Yang. It was a multinational paper. There was Chris Garcia from Stanford, who's a sort of a protein immunochemist, led it, but there were also ophthalmologists on the paper. There were Russians who contributed synovial fluid in the paper. And what this paper did is it analyzed by single-cell RNA-seq the cells in the B27 inflamed eye and in the B27 inflamed joint. And it was able to show that there was clonal expansion of T cells. So clonal expansion highly suggests that it's antigen-driven. And the state of the art now is that you can analyze those T cell receptors and see what they recognized. So this paper accomplished what I set out to do in 1978, and it was still a mystery. Why B27? And they showed that there were cells in the eye and cells in the joint from different patients recognizing the same antigens. I take offense when someone says ankylosing spondylitis is an autoimmune disease. I always think of it as more of an autoinflammatory disease that may be triggered by bacterial antigens. But I was wrong, because what they showed is that some of the T cell clones recognized autoantigens, and some of the T cell clones recognized common bacterial antigens. So it's both. Autoimmune and autoinflammatory. They didn't solve the chicken egg dilemma, which came first. I'd like to believe that it was the gut, but maybe not. But it's really brilliant and clarifying to the pathogenesis. And I started this soliloquy when you asked me why the eye and the joint. And I think this is a partial explanation. And every vascular system in the body has an address, right?
Yep.
So a disease like ANCA-associated vasculitis picks on certain blood vessels. Giant cell arteritis, certain blood vessels. Polyarteritis, certain blood vessels. Leukocytoclastic vasculitis, certain blood vessels. You're a pediatric guy, HSP, henoch-shoreline purpura, certain blood vessels.
Yeah, Kawasaki disease, yep.
Kawasaki's exactly an important cause of uveitis, right?
That's true. Yep.
Very important cause of uveitis. Bilateral sudden onset anterior, by the way. So I mentioned lymphoma. Okay. Why should there be lymphoma in the eye? There aren't lymphocytes normally present in the eye. How does that happen? Well, it turns out that the lymphoma in the eye is usually a B-cell lymphoma, and it almost always is accompanied by lymphoma in the brain.
Wow.
So it goes retina and brain. And of course, the retina is a lot like the brain. So I'm virtually certain, although it's unproven, that there's homing, that it didn't start in the eye, but these malignant B cells recognized receptors on the vascular endothelium of the retina and the brain, and that's why they ended up there. And so there's something homing. We've actually shown in a mouse model that lymphocytes can move from the gut to the eye. And I think Christine Kuhn at the University of Colorado has shown that lymphocytes can move from the gut to the joint. And others have shown that lymphocytes can move from the gut to the lung. So I'm hypothesizing that there are vascular addresses that are common to eye and joint, and that needs to be studied further.
That's incredible. I'm a big fan of autoinflammatory diseases, and I like to put on when I teach people about these, put a spectrum of autoimmune to autoinflammatory. And on one side, I have autoimmune diseases like lupus and rheumatoid arthritis. On the other side, I have the autoinflammatory diseases like, familial Mediterranean fever. And I always put the spondyloarthropathies right in the middle. And I guess that is the right place to have them. Thank you for that.
No, I credit Dennis McGonigal with first describing that spectrum. I call Dennis an immunotheologist. but I thought that was a really brilliant paper that helps me understand inflammatory diseases. And it's obviously the autoinflammatory is especially important to a pediatric rheumatologist.
Yeah, great.
And there are some autoinflammatory diseases associated with uveitis, like Blau syndrome and some of the NALP3 diseases as well.
That's right. And, the reason why I asked you about, referring patients to screen for uveitis is because some of the guidelines, I think, if I'm not mistaken, for like sarcoid and certainly for autoinflammatory diseases like the NLRP3, recommend screening, ophthalmology screening for uveitis. Whether, and I guess we discussed, whether or not that may or may not be necessary.
Well, if you have an infant who's, got NLRP3 associated uveitis like familial cold urticaria or NOMID.
NOMID, yeah.
They're not going to be complaining of eye problems. They probably have onset at age 1 or 2 or earlier, and they should be screened.
Got it.
But sarcoid, I do get referrals. I have a patient with sarcoid. Could you examine the eyes? I don't take umbrage at that because every adult should have an annual eye exam. There's no morbidity to it, or should be virtually no morbidity to it. But I'm not likely to find something. Every once in a while, a patient with sarcoid will have something that uveitis doctors call sarcoid spots. They're little scars in the peripheral retina, and you don't rely on the peripheral retina for useful vision. So they're usually asymptomatic. And when we see those scars, we say,
sarcoid.
Sarcoid. The only other time that I've ever seen scars like that is with TINU.
Interesting.
And TINU is interesting because you can get an interstitial nephritis with sarcoid. But
interesting.
They're different diseases, clearly.
Got it. Okay. So now let's talk about treatment. So you as a uveitis specialist, if you see, somebody presenting with, acute unilateral anterior uveitis, is your go-to going to be topical treatments, or when do you think about systemic treatments? And at which point, should a rheumatologist help with the management of uveitis?
Right. So it's a cliche, but the punishment should fit the crime. So anterior uveitis usually responds very well to topical corticosteroids, and sometimes we add a dilating drop to prevent posterior synechia, where the iris and the lens get stuck together. Anyone taking topical corticosteroids should be followed by an ophthalmologist who can do a slit lamp exam, because corticosteroids can raise the intraocular pressure, which, if it damages the optic nerve, we call glaucoma. And chronic use of topical corticosteroids will lead to cataract. So you want to titrate the amount of topical corticosteroid to the amount of inflammation and not overtreat or undertreat. A rheumatologist should be summoned, in my opinion, when the ophthalmologist cannot control the inflammation locally and needs help with some sort of immunosuppression. Or if the ophthalmologist is astute enough to know, this is a patient with sudden onset unilateral, and I know that sudden onset unilateral is frequently associated with ankylosing spondylitis. And there are some lovely, lovely papers showing that this is not the way that ankylosing spondylitis begins, but it's often the way that ankylosing spondylitis gets diagnosed. So maybe half my patients with sudden onset unilateral anterior uveitis have evidence for some sort of spondyloarthropathy. I remember vividly one patient who came in with sudden onset unilateral anterior, and he had recurrent episodes, and he was B27 positive. I asked him if his back hurt, and he said no. But you looked at his body habitus and you knew he had spondylitis. And I gave him a nonsteroidal, and he came back and he said, I am the Tin Man and I just got oiled. So rheumatologists can aid in identifying the systemic disease if one's suspected. And rheumatologists definitely have a major role to play in the immunosuppression. But it's a handicapped role. So I say it's a handicapped role because when you treat a rheumatoid patient or a lupus patient, you're able to assess if the treatment is working.
Right.
An ophthalmologist has got this incredible tool and ability to see the inflammation, to judge how things are going, but a rheumatologist is a step removed and only guessing. So a rheumatologist can say, are you seeing better? But sometimes people aren't seeing better because they've got a cataract or they've got a complication called macular edema, which is fluid in the central area of vision that hinders vision. So an ophthalmologist has a much better sense as to how much cell is present, and is the cell diminishing, and is the eye getting better. You really need some sort of eye specialist with whom you can communicate. And that's rare, in our era of RVUs and rushed practice and productivity and the way medicine is in 2023.
Yeah, I agree. So it's great to know so that, the importance of communication between the rheumatologist and ophthalmologist to make sure that the treatment is being effective. I always wonder, I've seen many patients that have recurrent uveitis, whether or not related to HLA-B27, who get topical treatments every time. So of those patients, at which point should we sort of nudge our ophthalmology colleagues that maybe the patient would benefit from a systemic treatment to prevent these recurrent episodes that require topical medications? And as you mentioned, these treatments are not benign.
Right. Well, and the episodes are not benign. I mean, if you have sudden onset unilateral, you may still have a good eye, but you've got redness and pain and probably work loss, and it's difficult to drive or read or use a computer. It can have significant morbidity for sure. We don't have good data that we can prevent attacks of uveitis, with the exception of HLA-B27 related uveitis. There's a smidgen of retrospective data that nonsteroidals reduce it, but I think there's a lot of skepticism and it's not great data. But there are at least 3 prospective studies, small studies, using sulfasalazine, and that reduces by about 80%.
Wow.
And biologics, if you can justify the cost and the risk of the biologic, monoclonal antibodies to TNF, not etanercept, but the monoclonals to TNF, do a good job of preventing attacks. Anti-IL-17 probably also a little bit, but certainly if your goal is to prevent uveitis, a monoclonal anti-TNF is the most reliable. But again, you often don't need to advance to that. I try sulfasalazine first.
Interesting. Sulfasalazine. And these are in HLA-B27 positive patients with uveitis, or?
Yes. And there's an incredible study from Spain. I think it was called the Sentinel study, and it was published in the eye literature. So many rheumatologists don't know of it. But they took nearly 800 individuals who were not known to have ankylosing spondylitis, and they had acute unilateral anterior, and they evaluated them. Not surprisingly, a little more than half, I think, were B27 positive, and those who were B27 positive were often found to have spondyloarthropathy. But about 30% of those who were B27 negative, they thought also had spondyloarthropathy. And, now that we have non-radiographic axial spondyloarthritis as a recognized entity, I think we're not quite sure of the specificity of that. So, I think we should be a little skeptical, but I do think that you can be B27 negative and have the phenotype of the uveitis that we see with ankylosing spondylitis, although there's a strong correlation between B27 positive and having uveitis with ankylosing spondylitis. So does sulfasalazine work if you're B27 negative? That's one of the things that the Yang Nature paper didn't evaluate. Are the same antigens recognized by the B27 negative group as by the B27 positive group? But I think sulfasalazine is benign enough that it's worth an empiric trial.
And what sort of dosing are you using for the sulfasalazine?
Great question. A gram BID.
Okay. Yeah.
500 milligrams, 2 pills twice a day, enteric coated.
Great. And then one question about refractory uveitis. So you've tried sulfasalazine, you moved on to a TNF inhibitor, the uveitis is still active, or maybe it was quiescent for a while and then it sort of flared up again. What other tools are you using these days to treat refractory uveitis?
Right. So if someone has the spectrum of B27 disease and it's refractory or chronic, it's most often psoriatic arthritis or inflammatory bowel disease, but not always. Occasionally, someone with ankylosing spondylitis will have.
I have a bad psoriatic patient with refractory uveitis, very, very severe.
Yeah, I worked with Ramanan, who's a very famous British pediatric rheumatologist who did the seminal studies using adalimumab for JIA-associated uveitis. And with his group, we described some children with early onset psoriasis and arthritis, and they had horrible, horrible uveitis. That's an aside. So what we do for refractory uveitis, as in, most of the patients with uveitis have what we call idiopathic disease, meaning that I can't diagnose a systemic disease. The inflammation is seemingly confined to the eye. And one of the research projects that we've tried to do is to use gene expression profiling of peripheral blood to see if we could better subset this group. And we've made some progress, but a lot more needs to be done. But I think that's possible. So that's an aside. But if someone has, let's say, sarcoid-associated uveitis or idiopathic uveitis, and it's severe enough to interfere with activities of daily living, meaning reading, driving, using a computer, and topical therapy and local steroids are inadequate, we try oral steroids, which is, as it is for rheumatoid arthritis or lupus, a nice quick fix, but rarely the ultimate answer. And then we add a steroid-sparing drug. And different centers have their preference as to what's the favorite steroid-sparing drug. I'm a rheumatologist. Guess what? Mine's methotrexate. So, and I like to use, if the patient can tolerate it, about 20 milligrams a week, a little higher than I might use in the patient with RA. I like azathioprine because it's inexpensive. It's been around a long time. I know that there's a wonderful group at Johns Hopkins, and I think their drug of choice is mycophenolate. The group at the NIH championed cyclosporin, and some people like tacrolimus, but I think those are fourth and fifth, both in terms of cost and tolerance, and they're no more efficacious than the methotrexate. So we use, a steroid-sparing, either calcineurin antagonist or most likely an antimetabolite. And then adalimumab has been FDA approved for children with uveitis. It was tested in JIA-associated uveitis, but the FDA approval, surprisingly, was for any form of pediatric uveitis. And there were 2 pivotal phase 3 randomized controlled trials for adults with non-infectious, intermediate, posterior, or pan uveitis. So forms of uveitis that A, are not due to an infection, and B, are not just anterior. And adalimumab, if you would have asked me, how good is adalimumab? I'd say, yeah, it's probably going to work in some patients, but it really works so incredibly so that the phase 4 trials where it's open label and they're following up, and you can use a little bit of topical corticosteroid or a low dose of oral steroids or an occasional periocular injection of steroids, it's about 90% successful in controlling the disease. And then there's also been a trial with a JAK inhibitor. The one that was studied is filgotinib. And those results are available on clinicaltrials.gov, and they have been presented at an eye-related meeting. And it's roughly comparable to adalimumab, and it's oral. But filgotinib has not been FDA approved for any indication in the United States. It's approved in the UK, Europe, and Japan, but the FDA has had qualms about toxicity in terms of spermatogenesis. So JAK inhibitors are an option if biologics fail. The other biologic that's especially interesting, arguably, is tocilizumab. Some of our patients have refractory disease because of this complication called macular edema. And now, when we evaluate patients, we routinely use optical coherence tomography, OCT. OCT is painless, quick, has no side effects, takes seconds, and we see the 9 layers of the retina. It's like a biopsy without, actually any invasive risk, right? So OCT will show you definitively if macular edema is present, and tocilizumab seems to be an excellent biologic for reducing macular edema, as if IL-6 is a major mediator of that edema.
Certainly. Jim, I'm feeling now like, actually, prior to this, to discussing with you, I felt like you did, back in the day when you didn't know what uveitis was. And I think, because of this conversation, I've certainly developed a renewed interest in eye disease, and especially eye disease with systemic manifestations. And I can't wait to, sort of take that into my practice and how I, see and evaluate patients with systemic manifestations and those patients, as we discussed, with uveitis, and trying to figure out if there's something else going on.
John, I've spent about 40 years being very grateful to rats. And if I've made you just a little bit grateful to rats, I'll be very happy.
Yes, I'm grateful for your knowledge and your obvious enthusiasm about the subject. This has been a fantastic conversation, and I really appreciate your time.
I'm grateful to you for your interest in the topic and taking time to talk to me and giving me the chance to share some observations. Thank you so much.
Great. Have a great one.
You too. Bye-bye.
Well, there you have it. A black globe no more. I've never felt so ready and excited to manage patients with uveitis in collaboration with my ophthalmology colleagues. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find all our show notes for this episode at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, please keep caring for those globes. And of course, stay healthy.